السلام عليكم ورحمة الله. مساكم الله بالخير. معكم حسن الشهري. Today we'll be talking about urology emergency, which I will be covering many topics, including renal colic, obstructive anuria, urinary tension, trauma, and much more. Beginning with renal colic, it's defined as acute and colicky pain that is in nature. Colicky, you can take it as pain so severe that it makes a person rolling. So whenever you hear the word colic, always assume that it's a severe natural pain. The primary site starts usually at the loin. Usually what is meant by the loin is somewhere around this area, and then it tends to radiate anteriorly and down to the groin. It may also reach into the labia or into the perineum, as well as the scrotum. It's most commonly progressive and almost always has perirenal tenderness, especially when it's intrarenal cause. This can be also assessed with the costovertebral angle tenderness. It's almost always a specific sign for pyelonephritis. So in physical examination, renal colic can be identified by history as well as clinical findings. Associated symptoms include nausea and vomiting, hematuria, and dysuria. These usually vary depending on the etiology of the renal colic. Commonly, though, it presents almost always together. Sorry, so there's supposed to be a slide about the etiologies of renal colic. I'll cover it briefly. So there is nephrolithiasis and pyelonephritis, and as well as obstruction. So whenever these three occur, it's most likely to cause renal colic. So nephrolithiasis would cause, especially if it's intrarenal, it will cause pain and inflammation inside the kidneys, which will cause a renal pain. You also got pyelonephritis, which is an inflammation and infection. And this will also induce renal colic and usually presents with nausea, vomiting, as well as hematuria. There's also obstruction, especially if it's bilateral obstruction. We get bilateral renal colic and the pain becomes more severe. This can also be identified using an ultrasound, seeing the different stages of hydronephrosis. This can also present as obstructive anuria, which we'll be covering soon. So about obstructive anuria, first of all, we define what anuria is. Anuria is defined as less than 100 milliliter urine output per day. So every day it's less than 100 milliliter, evidence of hydronephrosis. When these two present together, we label this as obstructive anuria. So anuria is just the number of less than 100 milliliter per 24 hour. And when it presents with hydronephrosis, we label it as obstructive anuria. The etiologies are different, but usually they are bilateral. We got urethral stones, as can be seen in this X-ray. You see this stone in the urethral, and these will cause obstruction of both renal tracts. We also got bilharzial strictures, also known as urinary schistosomiasis, caused by the parasite Schistosoma hematobium, commonly. These can be treated by antiparasitics, and as well as iatrogenic causes, idiopathic fibrosis of the kidneys, malignancies that are invasive and invade into the urethra or into the renal pelvis, ureter or the renal pelvis, which will cause usually causes unilateral obstruction, not bilateral, but there are some cases that causes bilateral obstructions. Also, the prostate or the cervix can cause an entire or a very long sequence of obstruction. So in the case of benign prostatic hyperplasia, which is one of the most common causes of obstruction, it will cause an obstruction in the bladder, causing a distended bladder, and then into the ureter, and then it reaches into the kidney and the renal pelvises. But that takes a longer process. So the more proximal it is, the more acute it presents. The workup is usually basic. We start with a basic metabolic panel, looking for any signs of renal function impairment, such as high urea and serum creatinine. We also look at an abdominal ultrasound. This is mainly done to assess for hydronephrosis stages. So there are some stages, especially the higher stages, grade 4 and grade 5, of hydronephrosis. We can label it as severe, and maybe we need to do a surgical intervention. A CT scan can also help us in identifying what the cause of the obstructive anuria is. It can be a stone. It can be one of whatever these findings are. We can identify it on a CT scan. So a CT scan is considered the gold standard imaging study for obstructive anuria, but we initially do abdominal ultrasound. The management usually starts with a DJ stent, a double J stent, as you can see here. It's a stent that just helps to relieve the urinary tract, the upper urinary tract, and then relieve the obstruction and save the kidneys. If this is not viable, we can also do a nephrostomy tube, but usually this is not always done. DJ stent is the best management for this. And always treat the underlying cause, as obstructive anuria is not primary, it's always secondary to something. So we got either an infection or structural causes, just as we mentioned over here. Now we get to urinary retention. Urinary retention is defined as urinary or inability to voluntarily empty the bladder. And it's also classified into two classifications, but mostly we go with the acute versus chronic urinary retention. But there is also mechanical and functional. Mechanical, such as the ones we mentioned for obstructive anuria, and functional includes something like distrusor dysfunction or neurogenic bladder. Now, when we talk about the differences, it's really vital to identify the differences because each has a different way or different approach to management. So the acute urinary retention is usually less than a day, or we can extend it up to 5 days. There are obstructive etiologies most commonly, especially benign prostatic hyperplasia as the most common cause. There is also other factors, as mentioned here, spinal anesthesia, pelvic surgery, especially long surgeries that causes post-operative urinary retention. It's more common in elderly. Also, it's sudden onset, painful, inability to void. So the patient wants to void, but he does not have the ability. He also presents with suprapubic pain. That's because of the distended bladder that is seen. And it's actually diagnostic, and we'll talk about it soon. You can also palpate a full bladder in the suprapubic region. Patient is restless and distressed. He wants to relieve his bladder, but he cannot. As for the chronic urinary retention, it's usually functional, not mechanical, as seen in acute. So a functional urinary retention is usually progressive, and this also includes benign prostatic hyperplasia. So, as you realize here, it can cause both. But usually, benign prostatic hyperplasia starts as chronic urinary retention. He feels the inability to void as much as he used to, and it's progressive. And then it can reach to a level that it becomes acute and severe or high amount of fluid that is in the bladder. It's usually painless in comparison to the acute version and may present with overflow incontinence or nocturnal enuresis. So the patients, especially the ones, as we mentioned, who have benign prostatic hyperplasia, they feel this retention is coming, but when the bladder reaches to a certain level or contains a lot of urine, the pressure inside the bladder may just help into causing incontinence. This is called overflow incontinence. Nocturnal enuresis is almost the same idea. The patient is not urinating, so when he's sleeping, it's around 8 hours of sleep. It's bound to increase the pressure inside the bladder. So this will also cause a type of overflow incontinence. The physical examination is typical. We start with abdominal examination and then a pelvic examination. We look into the meatus and make sure there's no penile cause for the obstruction. Digital rectal exam is important. As we mentioned, BPH can cause both acute urinary and chronic urinary retention, and it is the most common cause of urinary retention. واضح الشاشة؟ Okay. A complete neurological exam is also valid because some syndromes, such as Cody-Aquino syndrome, can cause a form of urinary retention, or a cervical myelopathy can also cause a urinary retention. So doing a neurological examination can help finding the cause of acute or chronic urinary retention. The workup is usually basic. The first thing we need to do is inserting a Foley catheter to relieve the urine distended bladder and relieve the patient in distress. That also helps us obtaining from a urinalysis and culture from the urine samples. We also do renal functions to assess that the kidney is it damaged from this urinary retention or not. Blood glucose is also the basic test to do. A renal ultrasound is important in two ways. First of all, this is not just a renal ultrasound. We do both renal ultrasound and we do a bladder ultrasound. The bladder ultrasound helps us in identifying acute urinary retention and chronic urinary retention. So in the case a patient presents with acute findings, we do an ultrasound, and then we find a distended bladder. What is the cutoff volume of urine to label this as urinary retention, especially acute? It needs to be more than 400 milliliter. The normal or the maximum levels we can reach is around 350 milliliters to 400 milliliters. That's when the patient really needs to urinate. If it's more than 400 milliliters, we label this as acute urinary retention. So how do we do? We just mentioned that in acute urinary retention, we just do an ultrasound. So how to assess for chronic urinary retention? We ask the patient to void. He voids as much as he can, and then we do an ultrasound. It's called post-voidal residual volume assessment. And then when we do the ultrasound, we find it's more than 300 milliliters. So that's how you assess for chronic urinary retention. What about the treatment? We always treat the underlying cause. As we mentioned, it might be BPH, it might be functional such as neurogenic bladder, prostatitis, or drug-induced. Some antimuscarinics can actually cause urinary retention, so we discontinue the drug. For BPH, we give them the drug of choice, which is tamsulosin. Prostatitis, we treat them with antibiotics. And for neurogenic bladder, we give bethanicol, which induces urination. Now we proceed with hematuria. It's defined as the presence of RBCs in urine. The cutoff score is more than 3 RBCs per HPF. It's classified into microscopic and macroscopic, and it may be painful and painless. The management is usually through a Foley catheter. We do a slow saline irrigation. We give IV antibiotics, especially if there's a suspected urinary tract infection. We do a KUB and ultrasound. And if it's painless, the next step is always a cystoscopy. So when a patient, especially if it's an elderly patient that presents with gross hematuria, key word is gross hematuria, next step would always be a cystoscopy. This management is the high yield management for hematuria. I will get into the pure management right now. So this is a stepwise approach to hematuria. We usually start for a urine dipstick. If we found positive for heme, we do a urinalysis, a microscopic urinalysis, to see if there's RBCs. If there's no RBCs, it's highly likely to be negative, or if you are still suspicious, you can do another dipstick to make sure, another urinalysis to make sure it's normal and not a false positive dipstick. If it reveals more than 3 RBCs, then it's considered a hematuria. Okay, so what do we do next? We assess the patient. Does he have any acute onset of flank pain? Then he has a renal colic with hematuria. We suspect for nephrolithiasis. It's a urological emergency. If he does not have any pain, we suspect a urinary tract infection. So what do? We check for symptoms of urinary tract infection, such as fever. We do urine WBCs. We do a dipstick that shows us if there is nitrates or not. If there is, it's a urinary tract infection. It has a different approach. If it does not, then we ruled out nephrolithiasis, and then we ruled out urinary tract infection. So what do we do next? We classify the hematuria into 2 classes. Is it gross hematuria or is it microscopic hematuria? In this case, if it's gross hematuria, we check for any blood clots. If there is blood clots, we do an abdominal pelvic CT scan, and urgent urology referral is required. If there is no no clotting, we check for albuminuria, dysmorphic RBCs, RBCs cast. These may give us many differential diagnoses. If any of these is positive, usually we refer to nephrology, and then we check for other certain cases that causes gross hematuria, such as nephritic syndrome, for example. So what if it is microscopic hematuria? We try to rule out if there is any history of vigorous exercises, or if the woman, or if it's a female patient with active menses, or patient with a history of trauma. we need to rule out this because this may give us a fake or a false positive test. Next, we do almost the same thing. We check for albumin, dysmorphic RBCs, WBC cast. If they are positive, we also refer to nephrology. If it's not positive, but any of these findings, there's a lot of findings. If any of these are positive, it's may considered to be a high risk. So usually especially if a person presents with microscopic hematuria and he's old, he has history of smoking, we start to suspect cancer. So we do a cystoscopy, and then we do the rest of the approach for malignancies. And then we got another causes of hematuria. It's called impacted urethral stone, which means that it is past the bladder, but it got impacted or stuck into a part of the urethra. So to make this easy, depending on the location, we treat. So posterior urethra, we just do a Foley catheter and we hope to get the stone out. In the penile urethra, no, we go actually for a suprapubic catheter to relieve the urinary retention. And then we hope that the patient passes it soon. We give him analgesia. If the patient has a urethral meatus impacted urethral stone, we do something called a meatotomy. This is when we cut open the meatus, the urethral meatus, to make sure that we extract the stone and prevent further urethral damage. Okay, so this is another case of urological emergency. It's called priapism. It is defined as a sustained erection for more than 4 hours that is not related to sexual stimulation and not related by ejaculation. This is mostly due to ischemia. It is classified into low flow and high flow. The low flow is the most common. Low flow is commonly associated to ischemia, and high flow is associated with trauma, especially saddle injury. Low flow can also be drug-induced. It can be in sicklers, especially if they're pediatrics. You start to suspect sickle cell disease. Autonomic dysfunction, bladder tumors are also another causes of priapism. The main clinical features include painful shaft with a rigid corpus cavernosum and a sustained erection. Okay, now for the urological trauma, we will take this stepwise, starting from the kidneys and then going down to the bladder and then to the urethra. The renal trauma is the first topic to be covered. Renal trauma is mostly due to blunt trauma, especially in a motor vehicle accident patient who had a high impact accident and experienced acceleration deceleration type of injury. Deceleration injury especially causes thrombosis into the renal artery and can worsen the renal injury. There's also penetrating trauma. It can be such as gunshot wound or impalement. The general workup includes a CBC, a basic metabolic panel, a urinalysis to identify hematuria, and the imaging choice is CT scan with IV contrast. Also, you can do a physical examination and you will find out loin thrombosis, and you can see it's almost resembling Gray Turner sign. Patient had a trauma or accident, motor vehicle accident, and presented with these signs, you raise suspicion for renal trauma. There is also certain indications for imaging. Not every patient who presents with hematuria should go for imaging. All penetrating injuries for the kidney injuries need to go for imaging to assess the grade of laceration. Any patient with blunt injury plus gross hematuria is indicated for imaging. Any patient with blunt trauma history, as well as a pediatric case, you need to do an imaging to rule out any damage. And a patient with blunt renal trauma, as well as physical exams consisting with renal trauma. So a patient becomes or presents with a history of renal trauma, blunt renal trauma, but you want to assess if the patient has any risk factors for kidney damage. So you do a physical exam, you find this ecchymosis with a history of blunt trauma. This is an indication for imaging. So this is a CT scan with the IV contrast. As you can see here in this kidney, there's a slight hypogenic lesion. This is a subcapsular hematoma. So this patient had renal trauma. It was blunt. We did the CT scan and we found an injury. So how do we manage these injuries? First of all, we need to know the grades. There's 5 grades for renal injury. There's 1, 2, and 3. These are considered low grades, and 4 and 5 are considered high grade. Grade 1 has no laceration, but there may be hematoma. As we can see with this patient, he just has a hematoma. A laceration less than 1 centimeter with hematoma is considered grade 2. And grade 3 has a laceration more than 1 centimeter, as well as plus minus vascular injuries. Grade 5 has a laceration with pelvic involvement. And grade 4. Grade 5 is devascularized kidney overall. So how do we approach these cases? Low grades from 1 to 3, we first start with a Foley catheter. We give antibiotic prophylaxis. And for grade 3 only, especially if the hematoma is expanding, we do angioembolization to stop further bleeding. As for high-grade renal trauma, hemodynamically stable patients, we do ICU. We admit him to ICU. We monitor the blood pressure, angioembolization of the hematoma, if there is expanding hematoma, and a DJ stent to ensure adequate urine output. Because if the patient has lacerated kidneys, we want to assess the urine output, and we want to help him to relieve the urine. So we put a DJ stent. If the patient is unstable, we don't do anything. We straight away take him to the OR and do an explorative laparotomy or exploration of the kidneys. If there's a penetrating injury, we also do not do the grading at all. We straight away go for surgical exploration. Bladder injuries, it's typical, penetrating or blunt trauma, pelvic fractures, because it's on the pelvis stuff, especially the pubis symphysis. And it can also be iatrogenic. So the general features include inability to void, lower abdominal pain, and gross hematuria. And for intraperitoneal bladder damage, the patient may present with signs of peritonism or peritonitis, especially if he has a history of UTI. He will most likely present with peritonitis. The diagnosis of bladder injury, most commonly it's done through a retrograde cystography using an X-ray, or retrograde CT cystography as seen on the left. So cystography will help us determine if it's intraperitoneal or extraperitoneal bladder injury. As you can see on the right, this is a retrograde cystography, and we can see that there is extravasation, but limited to the extraperitoneal space. It does not go inside the peritoneal space. As in contrast with this picture, which we can see a bladder injury that goes all the way up to the liver. So this is an intraperitoneal injury. And these two injuries have different management. This is why we need to do a retrograde cystography to assess if it's intraperitoneal or extraperitoneal. So how do we approach these patients? For patients with intraperitoneal bladder damage, we do skip to all of these, and we straight away go for immediate exploration and repair. We do not wait at all. And if it's successful, we keep monitoring the patient for any leakage. If there is extraperitoneal bladder injury, we check the patient for any signs of complicated bladder injury, especially if there is an involvement of the bladder neck, which means it's an irreversible damage almost. Open pelvic fracture is also complicated. Concurrent rectal or vaginal injury. If these are present, we need to undergo surgery to repair all of this. If there's just extraperitoneal bladder injury with no signs of these damages, we proceed with urinary drainage, and then we monitor the patient. So we put a Foley catheter in the patient. In extraperitoneal bladder injury, we just put Foley catheter and then keep him or reassess for 2 weeks. We observe him for 2 weeks, and it will heal by itself. We don't need to take him for surgery unless there is a sign of intraperitoneal extravasation or extension of the injury further. We proceed now with urethral injury. There is anterior urethra and posterior urethra. The anterior urethra most commonly is due to direct trauma. So the anterior urethra is all the way up to the membranous urethra, or at the end of the bulbar urethra. It's most commonly due to direct trauma, especially straddle injury. For posterior urethra, it's most commonly due to pelvic injury or pelvic fracture. A high note to know is that the bulbar urethra is the most common site of injury overall. So if a question asks you, and this is usually asked in board exams, which site of the urethra is the most commonly injured, you will mention the bulbar urethra. And now we need to assess the findings and compare between anterior and posterior urethral injuries. Both of them present with the urethral meatus hematuria. But for the anterior urethral injury, we can see that there is scrotal hematoma because it's extending into the scrotal cavity, but it has a normal prostate because it does not reach the membranous urethra. As for the posterior urethra, it presents with a high riding prostate, so a prostate is pushed up or back into the bladder or near to the bladder. There's also inability to void despite the urge, so patient may present with acute urinary retention. There's also a suprapubic pain. When you check for urinary extravasation, we would do a retrograde urethrogram to check. In this case, it will show superficial perineal space extravasation. You can also see extravasation into the scrotum and also around the penis or the lower abdominal wall. In this case, in posterior urethral injury, we will see deep perineal space extravasation, so somewhere around the prostate. We can also see retropubic space extravasation. So how do we diagnose urethral injury, especially if we suspect urethral or direct penile injuries? We do something called a retrograde urethrogram. And so this is a normal retrograde urethrogram. You can see the penile urethra, the bulbar urethra, the membranous urethra, which is the tightest, and also prostatic urethra. So all of these, that's how the normal urethra looks like. And here's a picture of a patient who presents with a direct trauma to the penis. He presented with bulbar urinary injury, and you can see there is extravasation into Beck's fascia. So this is diagnostic for urethral injury. The management is usually simple. If it's a blunt injury, we need to rule out any open penile injury. And then we usually just continue to monitor the patient and IV hydration, make sure he does not have any urinary retention. If the patient has a penetrating urethral injury and the patient is considered stable, we do immediate exploration and possible repair. If the patient is unstable, we provide urinary drainage, and then we keep monitoring and resuscitating the patient, and then we do repair after the patient is stable. And now finally, we go for testicular torsion. It's one of the most common urological emergencies. The clinical features are, before that, we just need to identify what testicular torsion is. It's when a testis rolls against the spermatic cord, causing sort of an ischemia or acute decrease in blood flow. This presents with abrupt onset of severe testicular pain or pain in the lower abdomen, typically swollen and tender testes. The patient may present with nausea and vomiting, and the testes appears to be abnormal position, usually high riding, as well as transverse testes. So how do we diagnose these cases? If we suspect testicular torsion, the first thing we should do is consult urology. Some questions present with that, and it's one of the choices that we consult urology before doing a duplex ultrasound. So the first thing we do is we consult urology. As a urologist, what do? You do a Doppler ultrasound of both testes to assess for the vascular flow. So as you can see in this picture, this is a picture of a person who presented with testicular torsion. The left testis has good flow, as you can see over here, and the right testis, it presents with no flow at all inside the testes. So this is how you differentiate between normal and abnormal testes. So you see on this right, it's almost like a flame Doppler. So what is this? This is considered epididymitis. Epididymitis sometimes presents with the same presentations as testicular torsion. So when we do an Doppler ultrasound and we see this finding, we rule out testicular torsion because testicular torsion does not present with a hypervascular testes at all. It presents with a hypovascular testes. So it's an important differential diagnosis to differentiate between testicular torsion and epididymitis. So how to differentiate between them using the history? Testicular torsion is always sudden onset. Epididymitis may be gradual onset or progressive pain. On examination, there are certain things that we need to identify. For testicular torsion, we find swollen edematous tender testes. We do a test that's called Pren test. We elevate the testes and see if it changes in pain. This is a sign that is specific for epididymitis. As you can see, it's positive Pren sign. So what happens? When we raise the testes, it should be relieved. When it's relieved, when the pain is relieved, this is epididymitis, not testicular torsion. Because in testicular torsion, even if you elevate it, the spermatic cord is still occluded. So there is no relief of pain. Another important sign is that testicular torsion presents with absent cremasteric reflex. Whereas in epididymitis, it still has a normal positive cremasteric reflex. There is also normal laboratory findings in testicular torsion, whereas in epididymitis, we might see inflammatory markers. So high WBCs, positive acute phase reactants such as CRP, ESR, or ferritin. So how do we manage these cases? As I said, we refer to urology first. The time window is 6 hours to treat the patient entirely. This is why it's considered a class A emergency. We first try to do manual detorsion. Lately, a lot of guidelines have been not recommending this, but for the sake of examination, manual detorsion should be attempted initially. Surgical exploration is required for all patients. Even if you do a manual detorsion and the patient is now okay and doing fine, surgical exploration is indicated and recommended. So what are the procedures that we do in surgery? Reduction and orchidopexy. So we reduce the testicular torsion, and then we put the testes back into its place. This is called reduction and orchidopexy. If this time window frame is gone, so the patient presents or he lives very far away from a hospital and it's been around 9 hours, the patient will sadly have a non-viable testes. So what do we do next? We do orchidectomy. We take out the testes entirely. So that's it for our lecture. I have a couple of MCQs. You can stop the video and then answer it yourself. So a 14-year-old boy is brought to the emergency department with a 4-hour history of acute left scrotal pain. Examination reveals a high-riding left testicle with severe pain on palpation. Urinalysis does not reveal any evidence of red or white blood cells. Which of the following is the treatment of choice at this point? So you can stop the video, put out your answer. Well, in this case, the answer would be surgical exploration. This is a typical case of testicular torsion. As you can see, he mentioned high riding left testicle with severe pain on palpation, and the urinalysis shows nothing. So this is most likely testicular torsion. We do surgical exploration, we do reduction, and orchidopexy. You might have said, why did we not do a Doppler examination? The findings are really close to testicular torsion. So when there's a high likelihood of testicular torsion, we skip the imaging and straight away take him to surgery. So this is our last question. A 29-year-old male was rushed to the hospital after a motor vehicle accident. He appears vitally stable. Blood pressure is 112/77. Respiratory rate is 19. Temperature is 37.2. And oxygen 98%. Upon secondary survey, there's bleeding per urethra. There is also lower abdominal tenderness, and patient is complaining of dull pain. A retrograde cystogram was done and showed the following picture. This is a picture. Which of the following is the next step in treatment? A, Foley catheter, immediate surgical repair, observe for 2 weeks, CT scan, or KUB. I'll stop the video, put on your answer, please. Well, the answer here would be a Foley catheter, because as you can see here, this is an extraperitoneal bladder injury. You might say, oh, we observe for 2 weeks, but in this question, it's asked for the next step. Next up, we put a Foley catheter, and then we observe the patient for 2 weeks until there's no extravasation anymore. These are my references, and thank you for listening.